So sizing. So things like epicardial fat obviously can clot. Okay, and clot is different texture. Acute clot may look the same as regular fluid. Okay, maybe anechoic, but clot that's been sitting there for longer may take on hypoechoic, pus, malignancy. And we talk about size. It's you know, people focus on, well, it's small, it's big. The reality is that it's the volume and rate of accumulation. Even a small effusion at a couple hundred mils in someone who's been stabbed in the chest can result in clinical tamponade. And so it's not necessarily always helpful to correlate size with impact. It really depends on the rate of accumulation, you know, and the kind of clinical scenario which you're confronted with. Obviously, in the trauma bay is very different from a patient who's up in the medicine ward who comes in with the subacute or chronic effusion. Those patients have a different circumstance with different risks. And we often see the loathsome epicardial fat pad. Most people's hearts have a little bit of fat, and we can often see a separation, which is usually anterior on top of the RV. And so the epicardial fat pad moves with the heart. Okay, it's not seen terribly well in here, and you may see it more clearly if you put some fluid in that pericardial space. But the way I kind of remember this is it's kind of like the fat hat of the heart. So just keep that in mind, that this is a common phenomenon and one that really has no clinical relevance besides being mildly irritating. Tips and tricks. Well, be aware that a pericardial effusion associated with aortic dissection and inferior MI, because those are obviously a very concerning clinical picture. And yes, you found the effusion, but it's how that relates back to everything else is what matters. And obviously that's a concern for a significant dissection and hemopericardium. And also be very concerning post-procedure. So, you know, a small effusion, again, in a medical inpatient may not have great significance, but, you know, if they just had a cardiac cath, for example, they're coming back and they have an effusion, it certainly may carry a higher degree of concern. And then when we talk about fast scans, we can actually improve sensitivity by performing the scan more than once. And so patients that come in who are hemodynamically unstable, we might look and say, oh, there's no pericardial effusion, and they continue to be unstable from a hemodynamic standpoint, you can look at it again. And once you evacuate a hemothorax, the hemothorax may actually be from a tear in the pericardium. And so it's important to consider that you don't necessarily always rule it out when you look once, okay, especially in a patient who's had penetrating trauma. So size, if we're looking at strict size criteria, we look at small being less than 1 centimeter separation, moderate 1 to 2, and large greater than 2 centimeters. And this is, again, it correlates poorly with the hemodynamic effect on the heart. But it can be a clue to the etiology and chronicity. You know, things like a subacute or chronic effusion, and things like tuberculous pericarditis or hypothyroidism or malignancy versus the acute penetrating trauma. The important thing is that you measured end diastole, okay? Because in end systole, the heart contracts, and as the heart contracts and the LV cavity gets evacuated, it can actually make the pericardial effusion look larger than it really is. So the point is to measure it at end diastole, okay? So keep that in mind when you're trying to estimate the size of it. Okay, generally effusions that are only present in systole are small, and we care very little about them. When you have an effusion that's present in systole and diastole, that's when it can become more of a problem when we look at the other criteria. Again, we're not focusing on local or loculated effusions, but the point is to look at more circumferential. So here's kind of a small to moderate effusion. So we can see here this pericardial separation in anechoic space, which is anterior to the ascending thoracic aorta. There's also a bit of anechoic space here, which is anterior to the RV or RVOT. Compare this to a large effusion. Okay, so there's no marker, there's no distance there, but I think it's roughly around 4 centimeters. So this is a very large effusion. And this is when we see that clinical effect of the heart swinging, and we see that electrical alternans on the ECG because the pericardium is really full of fluid. Okay, and a patient like this, they actually may be stable because if it's accumulated over the period of 2 months, okay, they may come in, they may have community-acquired pneumonia, but maybe they're on dialysis and you take on a bit too much fluid, and then you actually create a volume-dependent tamponade where where what happens is you're actually changing the intrapericardial to intraventricular pressures, and you can actually put them in tamponade if they weren't in tamponade, just by dehydration. So that's the important thing. Is it's not uncommon to see a patient that you say, oh, I think they have tamponade, and then 4 hours later, you know, let's say cardiology does the formal comprehensive echo, and they say they're no longer tamponade. Well, that's actually, quite honestly, should be like an effect of your IV fluid resuscitation. Okay, because you should really be bolusing them fluid, 2 or 3 liters, 4 liters, to really bring up those intracavitary pressures and reduce clinical tamponade.